Hi everyone, my name is Sadhana Devaraja and I'm Managing Director here at Health Begins. Thank you for joining us today for this webinar on designing measures for success. Before we start, we would like you to know that this webinar will be recorded and we'll be sending this recording out to all registrants after the webinar. All participant lines are on mute. If you have a question for us, please enter it at any time in the question box that appears on the GoToWebinar doc. It should appear on the right-hand side of your screen, and we've reserved time at the end of the webinar to be able to answer any questions that come in through that question box. This presentation will last for 1 hour, and before we dive into the content, I'd like to take a moment to introduce today's speakers and review some of the learning objectives. At the end of this webinar, we expect that attendees will be able to identify current challenges to measuring improvements in social determinants of health, describe approaches to finding and refining measures for upstream success across different levels, and pinpoint resources to assist them in selecting appropriate social determinants of health measures. A reminder that you can submit your questions and comments via that question and answer pane on your GoToWebinar doc, and we'll be answering questions at the end. And if you'd like, please tweet at Health Begins during today's webinar, and we can capture some of those comments as well. So today's presenters will be our very own Rishi Manchanda, President and Founder at Health Begins, Brita Roy, Assistant Professor of Medicine and Director of Population Health at Yale University School of Medicine, and Karis Grounds, VP of Health and Community Impact at the Community Information Exchange 211 San Diego. Thank you all for joining us today, and with that, I'll turn it over to Rishi.
Thanks so much, Sadhana, and hi everybody. Thanks for joining us today. It looks like we have a good crowd of folks attending and tuning in for today's presentation. I'm really privileged and excited to be joined today by Brita and Karis, and I think all of you will enjoy today's conversation. A little bit of an introduction for those who don't know about Health Begins. Health Begins is an organization that was started a little while ago. Our main purpose is to improve care and the social determinants of health, and we do so by making clinical and community partnerships more effective, doing a variety of different types of support, from strategy design to implementation support to bringing ideas around social determinant solutions to scale. And it's because of our work across a whole variety of different health systems and plans that we're seeing this topic today being more and more relevant. And I think this question of how to design measures for success is relevant for, I think, all of you who are tuning in, and relevant for many of the stakeholders, of course, and the beneficiaries that we care for. To get a better sense of who is on the line today and to understand what your own journey, where you're at in your own journey in terms of addressing social determinants of health and specifically designing measures for that, we thought we'd launch our first poll for today. So let's go ahead and start with our first poll, which is this question. Does your organization have a measurement strategy for social determinants of health? You can see the answer choices there, and we'll give you about 15 seconds to answer accordingly. Great. A few more seconds. And here we go. So looks like a third of folks who are joining right now don't, to their knowledge at least, have a measurement strategy in their organization. It looks like nearly half are developing a more formal measurement strategy, which is pretty promising and exciting to hear about. Sounds like a minority of folks right now, about just 11%, have and are using a formal measurement strategy to address social determinants of health, while others are updating it. So that's a really helpful reference point. Let's go back to the presentation and also get ourselves oriented to understand not just where you're at with your strategy, but also what types of data sets or tools your organization is using to measure and track social determinants of health. So this is the second poll before we launch into our presentations from our guest presenters today. And let's go ahead and launch the poll now. And the question here is, what types of data sets or tools is your organization using to measure and track social determinants of health for your populations? You can see we also use HRSNs, health-related social needs, in one of the answer choices. We understand that for some stakeholders who are tuning in right now, you might be defining your work in the social determinants of health space through specific health-related social needs. But go ahead and select all that apply. And again, in this answer, you can select more than one. Let's give it another 5 seconds. Great. So for more than half, a majority of folks, social screening tools are being used at this point to identify individual health-related social needs, followed by the use of community-level data sets that use and aggregate local social determinants of health data. It looks like a fifth, folks are actually geocoding their data in the form of electronic health record data or claims data to identify place-based risk factors. A smaller number are using risk analytics software that specifically includes and analyzes social risk factors. And then finally, 4 out of 10 of you are involved in, it looks like, in leveraging either health information exchanges or perhaps community information exchanges. And so with that, as we go back to the presentation, now that we have a better sense of who's on the line and your respective experiences when it comes to designing measures of success for moving upstream, we wanted to set the stage for today's conversations. We understand that based on our experience with Health Begins and our conversations with friends and partners, including Karis Grounds and Brita Roy, who you're going to hear from momentarily, that there's currently a lot of challenges when it comes to measuring success, when it comes to designing measures of success for moving upstream. One of the chief challenges is that many who are involved in this work mean different things when using the very same terms. So you can see here on the right the Tower of Babel, in which many different groups of people were using very different languages. It led to quite a challenge. We don't think that we're experiencing a challenge in terms of biblical proportions when it comes to trying to address social determinants of health, but it does illustrate the fact that we're all using multiple different meanings when we're using sometimes the very same terms, and that lack of coherence in the way we talk about social determinants of health is certainly one of the major challenges when it comes to measuring success. Today, actually, we're hoping to take that on, to take on that challenge and do so by presenting a couple of very basic framing questions. When it comes to designing measures of upstream success and creating that common language for health data, the first framing question we want to introduce to you to think on as you're hearing our presenters today is, how are we thinking, talking, and acting with respect to health and social determinant of health data? What are our objectives, in other words? And how are we actually thinking, talking, and acting when we're trying to meet those objectives? And the second related question we want you to think on as you hear today's presentations are, what are the different ways to identify the data we have and the data we need right now? So how are we thinking, talking, and acting with respect to this data, and what are the different ways to identify the data that we have and also to identify the data that we need? So with these two broad questions in mind, you're going to hear now some more really concrete and wonderful presentations from today's presenters. And as you do so, you're going to hear them give their own innovative kind of examples of how they've started to expand what we consider to be the dimensions and creating this new language of defining social determinant of health data. You're going to hear them describe their own objectives for their work, describe how they worked with the data that they had, and described what they did to be able to generate and analyze data that they needed. And as you do so, you're going to hear them touch on, each of them is going to touch on a variety of different dimensions. Some dimensions that are, I think, pretty well understood by many who are tuning in today, and some that might be new for you. So you're going to hear some discussion about how geographic or area level measures can be useful. You're going to hear another dimension about how to move from a binary into a continuous framework when evaluating social risk. You're going to hear about the importance of looking at the factor of time, the dimension of time, I should say, in terms of the immediacy of a social need and the chronicity of a social need and how that can be helpful in identifying risk. And hear again about different levels of addressing social determinants of health and collecting social determinant of health data as well. And especially from Brita, you'll hear a discussion about what it means to shift from a framework that looks at the absence of social risks into the present of well-being and resilience. And so on. So we're setting the table here so that you can have, I think, a really robust engagement with our speakers today. And again, a quick reminder before I turn the baton over to Karis that there is the Q&A pane available. So as you're listening to today's presentation, please take any questions that you have and put them in the pane. And at the end, we'll have enough time to be able to review your questions. So with that, let me go ahead and turn the baton over to Karis Grounds. And Karis, it is all yours.
Great. All right. Okay, sweet. I think I'm set up. So thanks so much, Rishi and Health Begins for having me. I'm very excited to be talking about this concept, I think very important and very timely with a lot of what is going on in our communities and across the nation. So my name is Karis Grounds. I work at on the Community Information Exchange /201 San Diego, and I'll be primarily talking about a tool or concept we call the risk rating scale. So I'll start off by kind of giving you a little bit of an overview of why we came up with this concept and why we're really trying to measure social needs. So part of it is as all of us are struggling with a lot of the concepts that Rishi was talking about, there's truly like a lack of standardization across the needs for how to measure or how do you assess social determinants of health risks. So because this is kind of although it might be a long-term kind of case for a lot of CBOs or nonprofit partners, the combination of healthcare and social services is a new concept. And so there's a lot of challenges around how do you standardize the work we're doing. Healthcare has a lot of standards around how they're measuring things and looking at BMI or A1Cs, but healthcare kind of is behind on that. And so, social services are kind of behind on that. And so there's really a lack of standardization of really how do you measure these social needs. Return on investment, I think all of us are really trying to move towards how do we prove what we're doing is successful and what does it mean to have an ROI. And so the concept of that is really challenging as you're trying to kind of measure some new things. Social service organizations are often specialized in domains or target populations, meaning that that a lot of social services might focus just on housing or might focus just on food or social support. Although there's multi-sector social service organizations, it's often challenging to be able to collaborate directly with an organization that looks at all the different social determinants of health, which creates even more challenges in really being able to figure out how to measure things because everyone's kind of on their own different use cases or working with different populations or clients. Healthcare versus social services, this is something I can attribute to Rishi, this concept of the level playing field, and really that healthcare has a lot more investment and support and money and resources accounted for what healthcare has versus social services. So it creates this unlevel playing field, which makes it challenging to be able to measure or have the same data or metrics to look at that. Healthcare has a lack of familiarity with social service ecosystem. This is a concept that I think Lauren Taylor recently put out in an article. If you haven't read, you should absolutely. I think it was in Health Affair. But really that healthcare is really trying to work with social services, but there's really a lack of really understanding how social service ecosystems work and how you build that trust and accountability, which creates additional challenges around how to measure and look at data. And then the whole concept of screening versus assessment really looks at a lot of what we measure is, and what healthcare measures is really the positive negative. So are you food insecure? Are you homeless? Do you have social supports? It's very yes or no. And the concept that we've really tagged onto is this idea that we need assessment and that it's really missing the whole continuum and the whole picture if you're just looking at screening. How do you really measure those changes? And so that's really where the risk rating scale kind of came out of. And so we knew that there was a lot of tools and resources around screening, but there wasn't really necessarily anything that kind of took an account to the holistic situation. And so the concept of the risk rating scale really started in creating kind of a universal language and cohesion among all of these standards. And so clinical screening tools exist, but there's really a lack of comprehensive or a continuum that really captures that holistic view of what's going on. And so what this tool is designed to really do is create shared language across the system of care. And so as we're working with healthcare and social services, it's easy for healthcare to say positive, negative, but in social services or really improvement, you can't really do much with a yes or no. You want to be able to measure that and look at it from a holistic situation. And so creating some shared language or being able to know, okay, when you say crisis or critical, what do you mean by that? And then what are those data points that kind of back that up? We wanted to really understand the client situation and the nature and severity of the need. And so we actually created some constructs, which we'll go over, that really talk about what are some of the things Rishi kind of talked about, and the immediacy and the different elements that really make up whether someone's going to be able to really address the need, the upstream issue that's really going on with their situation. It helps to measure or create a risk baseline. So with binary or positive, negative, you can only go yes or no. Your answer your post test isn't too exciting. And so we really wanted to create a framework that allowed for shared measures and change over time. So you actually be able to see a progression, and that you could see where people maybe could move up and then move down, and be able to actually look on it on a continuum standpoint. It's a tool that's really used for care planning and intervention. So we wanted something that would this information, what can I do with this? How do I actually move this person up towards a better state? And so that's also how we use it. And the last component of what the risk rating scale does is it actually aligns risk with resources in the database. So as healthcare is working more with social service organizations, knowing which housing resources are the best fit for their situation, there may be 15,000 resources in the database, but really based on their situation, this is the best fit based on their immediacy or their needs. And so really helping to look at resources that align with that. And so the methodology behind that really looked at identifying existing models in the system. So we're looking at all the different social determinants of health. As we know, there's a lot of different tools out there, and really assessing what's the most impactful for an individual, because there's a lot of community level, kind of high, pollution and things that are environmental that not necessarily the individual has control over. And so we really looked at what could be impacted on a community level and individual level. And then we used a risk rating scale, which is based off of a self-sufficiency matrix that is very common in some social service organizations, and use the concept of the measures, a crisis to thriving state, to be able to look at how we could measure a change over time. And then we actually came up with, looked at assessment. So we pulled a whole bunch of evidence-based tools that are already available in the community. And then we pulled together a whole bunch of local kind of subject matter experts, and basically looked at the tools that everybody was already using for intakes for housing or food insecurity or social support, and pulled all those tools and started looking at all of those questions that how can we go from these 500 questions into maybe 15 to 20 questions that could be used to be able to better identify the needs. And then we scored each one of those and rated each one of those to be able to create a weighted assessment rubric that'll actually allow us for each domain to get a score. And then we continue our updating and validating that with our community partners and with our own assessments. So we came up with 14 social determinants of health. So here are the 14 social determinants of health that we currently use, and we have specific assessments that look at any one of those. Probably most popular: housing, safety and disaster, transportation. All of these are different kind of elements that kind of look at the individual. And the framework that we use, I was kind of mentioning this, it's a crisis to thriving. But we looked at three primary constructs. So we looked at immediacy: how soon does a person need help? So if someone's homeless currently, they're in more of a crisis than somebody who is, at risk of losing their house in a week or two. And so that really changes their risk score around their immediacy. Versus knowledge and utilization really focuses on, does the person know about resources in the community? Are they able to access them? Have they utilized them? So their knowledge, whether someone's access services is completely different than somebody that hasn't or knows where to go. And then we really use barriers and supports, the last construct, to look at what are the barriers specific to that individual that prevent them from accessing the resources or domains that would help support them, and what social supports exist for that person. So if this person's homeless and they can couch surf on their, uncle's couch, it's really different than somebody that has no supports in the community whatsoever. So that's really kind of accounting for all the different, that's the framework that we really base it on. And this framework is different for every kind of situation, and in each one of these, so for example, barriers could be something like, for housing specific, whether or not someone's been in jail could or have bad credit could impact whether or not they're able to get housing. Versus for food insecurity, those barriers might be a food desert or undocumented, not having status to be able to access those resources, make it very, very different. And so that's really what it counts for in that framework. And so the way we actually utilize this and value this is really we use it through our community information exchange. So we have a tool in the community that individuals consent in to have their data shared across a bunch of different network partners. And so it's a tool that helps for across our community. Doesn't matter what organization you work at, whether it be healthcare or a housing provider, this color risk helps to understand like where somebody falls on any one of those social domains. And then when you click into any one of those, you can see kind of at the bottom, it'll give you a snapshot of what actually is going on in their situation to give them a critical state. And so that changes the interventions or the care that our community is providing to that individual because they have a better insight into what their situation is. And additionally, we use it for kind of our care coordination or outcomes work. So we use it as a tool for case management, but we also can see that when we actually are doing pre-post tests with the risk grading scale to see that score change for that individual. And so that's shown up in some of our work we've done with some of our hospital partners, where we've actually seen readmission rates decrease. And if you look on the right-hand side, by decreasing that vulnerability, so from moving that individual from maybe a crisis state to a vulnerable state, we saw a decrease in any one of those domains. To be able to, that directly correlated with that hospital readmission decrease. So hospital utilization decreased by intervening on their social community resources that by providing them services that would help them move up that scale or connect to services that would help their overall situation. And so at the bottom, you actually see some of the needs that the different patients had, and then their decrease in vulnerability and their hospital readmission overall. So what we really are starting to understand is the bigger picture that's really going on with the individual, the context, the equity that's really impacting whether or not somebody can access resources. And so by moving from that binary to that continuum, you're really understanding the holistic picture and really the intervention that's better supported to help that individual thrive or do better. Our additional goal is to really test this in other communities. We'd like to expand this for other communities that are wanting to move further ahead. So that's really where we're trying to move to understand what other communities are doing and how do we align this type of work so you don't have to redo it again because it's a lot of work. So we want to be able to kind of test this and share, and then also do research in this area specifically that looks around, as a model for intervention, as well as shared language in data sharing like communities, like the Community Information Exchange. So I'll end there and hand it over to Britta, and I think we'll take questions at the end, but that will be helpful to kind of understand it in a larger picture. So Britta, I'm handing it over to you. Unless Rishi, you're talking before that.
Nope, I'm on next, and hopefully, all right. Hopefully everyone can now see my screen. Thank you very much for that really engaging presentation, Karis. And I think it sets up what I was planning to present really well. And at the beginning of the hour, Sadhana mentioned I'm at the Yale School of Medicine, but I also am part of the metrics team for the 100 Million Healthier Lives movement. And what I present today is really on behalf of our entire team from really all over the place, members from UNC, Cincinnati Children's, Kaiser Permanente, and Shoma Stout is the executive lead for 100 Million Healthier Lives. So a few years ago, our team was tasked with measuring healthier lives. And so the first thing we thought about is, well, what is health? And coming from medicine and the medical field, we often think of health as simply the absence of disease. But just the absence of disease does not really mean that someone is really functioning at their highest potential. So we really wanted to shift from thinking about health as the presence or absence of disease, like a binary component, as kind of Karis first mentioned, into really more of a continuum that includes the positive end of the spectrum as well. So we wanted to measure the presence of health, which includes positive functioning, well-being, and a sense of thriving. So in 100 Million Healthier Lives, we adapted a definition from the World Health Organization where we stated that health is really a complete state of physical, mental, social, and we added spiritual well-being, not merely the absence of disease or infirmity. And our hope was that through working with multiple communities around the country and the world, that together we could develop programs and change policies and systems in order to create healthier and higher well-being lives. So to measure well-being, there are some measures of well-being out there, but many of them are quite long or they are proprietary. And for this movement, working with multiple stakeholders and many communities and grassroots organizations, we needed more data on health and well-being, and data that these groups could be using for continuous quality improvement. And because of that, we felt that there was really a need to create a measure of health and well-being that is very short and concise and can be administered by any community, grassroots organization, or layperson. So we compiled a set of 7 questions comprised of validated items. And in this adult well-being assessment, we also have a version for adolescents between ages 12 and 18. And this assessment includes questions that assess kind of an overall sense of well-being or overall life satisfaction with the first 2 questions, but then also those domains of well-being that I shared with you in our definition. So it includes physical, mental, social, and spiritual well-being. But then taking a step back and thinking about what really influences a person's health and well-being, it is the context within which they live. None of us, live alone or in a complete silo, and our health and well-being is very directly impacted by the places and organizations that we live in and the systems and policies around those. And so with that understanding, it was not just the well-being instrument that we needed, but rather a whole measurement ecosystem to be measuring the determinants of health and well-being at these various levels. So we came up with a sort of example infrastructure so that people could start thinking about what are not only individual level or people level measures that give us a sense of their health and well-being, but also measures at the community level or place level and system level. So an example may be, for physical health, length of life or life expectancy might be a measure of physical health at the individual level. But at the community level, perhaps walkability is a way to measure a determinant of physical health at the community level. And federal funding for pedestrian and bike programs might be a systems level measure that, again, would help support physical health in that community. And the list can really go on, but this just gives you at a high level a sense of the types of measures you might start thinking about for the various domains of health and well-being at the individual, community, and system level. We compiled all of these measures into a freely accessible online platform called Measure What Matters. It is open and available to anyone around the world. You can go in and create an initiative. You can also search for measures. The well-being assessment I shared with you earlier is on there, but there are also many other measures at the individual, community, and system level. And those measures, if they are connected to available secondary data, for example, through the census, that information is already brought in through the platform. In addition, you can create questionnaires and administer them through this online platform as well. So you can collect your own data, and you can track and trend how you're doing over time using run charts, again, within the platform that will automatically update as you either enter in data or more data is gathered through secondary sources. So my hope is that after this presentation, that folks will log into this system and see, what may be available to help your local initiatives. So that is all I have for you today, and I will hand it back over to Rishi.
Thanks so much, Rita. And Karis, thank you as well for a really great introduction to the work that each of you has been engaged in. And I think gauging the response so far in terms of the Q&A that have been coming through online, I think there's a lot of folks who are eager to learn more. Let's jump into kind of a Q&A that I'll facilitate some questions from my side in response to what you guys presented, and then we'll start to field some questions from folks online as well. And for those online, just another reminder, if you haven't already shared your questions, please do so using the Q&A pane, and we have our team viewing and triaging those questions so we can try to address as many as possible. So I want to go, Karis, to you, and remember that from the top of this presentation, we were thinking about how to expand our understanding of measures of success in moving upstream, and we reminded everybody to try to think of some framing questions as they were listening to each of your presentations about what their objectives are, what data they had access to, what data they wanted, but especially to think about the different dimensions, the different types of data that were available, the different layers or levels of data that are available. And I wanted to hone in on, Karis, what you touched on in a great way through the risk rating scale presentation around the sense of binary versus continuous measures, as well as the sense of immediacy. And I'm wondering if we can dive a little deeper. First, can you recap those three domains that you use to assess the kind of vulnerability to kind of move from binary to continuous? I remember one of them was, of course, immediacy. And I also think that you mentioned knowledge and barriers and supports. Can you tell us a little bit more about what it went into choosing, if those are the right ones, what went into choosing those three domains to assess kind of going from binary to continuous?
Absolutely. So I think that, to your point, I think that there was immediacy, the three concepts. So we have immediacy, we have barriers and supports, and we have knowledge and utilization. And so initially, as anyone might do, it kind of organically happened in the sense of looking at kind of what were the main questions that were being used in the community and nationally in a lot of these frameworks, and then locally in our own, even within our own organization or other social service organizations, and being able to identify what intervention you need to provide or what do you want to do that's different. And so I think that those concepts of immediacy kept coming up as a primary indicator, of course, and being able to know how quickly do you respond to the need. So if someone's in this situation, how fast, similar to the way you triage a patient in a hospital, or how we kind of look at those needs in a healthcare setting, immediacy is always kind of one of those things that what came up most often and is scored. We actually weigh each one of those contracts higher. So immediacy is weighed higher than knowledge and utilization and barriers and supports. Knowledge and utilization really is meant to be around like what resources they're accessing or what services or tools or kind of supports from a resource side or a community-based side have they accessed? And so have they been able to utilize some tools? Do they know where to go to the grocery store, or do they know where to a farmer's market, or do they know where to get a shelter? Those kind of things is really understanding their ability and to access those resources that would help support in their situation. And if you don't, then it makes it more and more challenging to be able to improve your situation if you don't know where to go. And then the last construct is really around barriers and support. So we really wanted to account for a lot of the issues that are specific to domains that impact whether someone can thrive or not. And so it's kind of the jail example or the credit history example or the food desert example, like those are all specific to your community and or where that person lives in their neighborhood, or based on the historical experience, or what it's almost like a way to provide informed care a little bit, because you're really understanding what the challenges that person is facing in order to help support them up towards that continuum. And so we know that we might have to, if they have more barriers, you might have to invest more, or you might have to get them connected to a different program because of that situation.
Mm-hmm.
And then also the supports is a part of that too. Can they leverage anyone else?
Kara, so really appreciate that. There's two thoughts that I wanted to just highlight in terms of how I find that to be really, there's many aspects of the risk rating scale that I think are innovative, and I think are promising. A lot of folks are tuning into that. So we'll get to those questions in a moment. One of them is about the ways in which you kind of created the classifications between, say, crisis to thriving. Can you give us a little bit sense of how, what criteria were used, who was involved in helping to identify those different categories of, why those categories, why 5 instead of 2, or can you give us a sense of how you came up with that gradient, if you will, from crisis to thriving?
From crisis to thriving.
Mm-hmm.
So it's based on, as I kind of mentioned, so it's based on the kind of the concept of the self-sufficiency matrix, for sure. You have different elements to be able to measure that. And I think, as we've done, we're up to about 70,000 assessments, and we're continuing to refine those, every day as we get feedback from our community partners and other community members, or, other leaders that we're looking from the national scope as well. And I think that what we really wanted to account for is small movements and changes. And so really being able to truly measure how someone moves towards thriving, if we really want to look at the whole person and kind of the bigger picture. I think the reason why we use those 6 different kind of plotting points is because little change, we needed to be able to see small wins. And so we know that getting someone housed, for example, specifically in California, is going to take a lot longer than somebody in maybe another state, but being able to see really those little movements towards, you go from homeless to at least being, getting connected into a coordinated entry system or some sort of housing management information system. You still might be homeless, but your movement went from crisis to now critical, because you saw you actually got enrolled in a program, or you utilized some sort of service. So we really use that gradient based off of the best practice tool of the self-sufficiency matrix, and also the idea to be able to measure small changes and moves as a social service partner. That's really important to be able to show those changes.
That's really great. Brita, I'm gonna pivot over to you in a moment and just make this comment that what I particularly appreciate about the additional domains, besides just immediacy and the knowledge and utilization behaviors of that person, the patient, the client, the beneficiary, is this notion of assessing for barriers that may exist for that person to access a resource to address that need. There's a great article that was put out about 8 years ago, I believe, maybe a bit more than that now, called Capability as Clinical Success. We'll send out information about this for those who are tuning in, but if you are multitasking right now, feel free to Google Capability as Clinical Success and you'll come across that article. It goes to this notion of using the sense of human capabilities that has been used in international settings, promulgated by folks like Amartya Sen, a Nobel Prize winning economist who talked about capabilities and freedoms, and rather than just the presence or absence of poverty, for instance, to be able to understand human development. And so the notion of bringing that capabilities framework into our assessment of social needs moves far past this point of screening for whether something is present or not, as Karis, I think you pointed out really nicely, and then B goes into the sense of not just assessing whether the individual has a problem, but whether the problem itself is that they have a barrier in accessing the resources, meaning they don't have the capability to address it. And so wanted to highlight that and then use that as a baton pass, Brita, to you, because I think this notion of understanding capability, of understanding the barriers that individuals experience, is a reflection, again, of a community level phenomenon. And wondering, as you were hearing Karis describe their work, what intersections do you see with the work of 100 Million Healthier Lives, the work of identifying resilience, et cetera? I'm curious how Karis's work and the work of the barriers, especially, and the access people have to resources, kind of fits within the measurement framework that you guys are developing.
Yeah, thank you for that question and comment. And actually, a lot of what she said really resonates, and especially what you were just describing as a capabilities framework is really analogous to what we call in 100 Million Healthier Lives, moving from a sense of scarcity within communities to one of abundance, and thinking about communities that, even if by our standards they are low income, that there are a lot of assets and resources within the communities that can be leveraged to improve health and well-being. And I think by shifting our mindset to an asset-based mindset and to one of abundance, we are really, I think, supporting communities to be able to become what we call communities of solutions, communities that can, really start thinking about how to partner and support themselves in ways that make sense for them. Going back to your question about, the binary versus continuous measures as well, thinking about health, or really any other determinant of health or well-being on a continuous scale, not just the presence or absence, is critically important. And I think it also really resonates with the community members as we work with them as well, because their lives are not black and white, and there are various shades of gray, and there are ways to improve along those continuum. And so by actually measuring along a continuous scale, along many different outcomes, can be really, really valuable for kind of quality improvement or improving health outcomes, but also, again, just for the mindset of the group of folks that's really trying to improve things where they live.
Rita, that's great. I appreciate that. And I think in about 3 minutes, we'll go to Sadhana, who will read through many of the questions that have come through. I wanted to, based on this conversation, just kind of go through the gauge where folks are at in terms of the audience right now based on the conversation so far. And we'll launch another poll question here. You may have an audio problem on your side, but let's go ahead and launch this. So for those who can hear, based on what you've heard so far, how would you most like to expand the way your organization measures social determinants of health? Another 10 seconds. Great. So for about half were able to vote, and thank you for those who were able to get your answers in before we did the quick poll. It looks like a quarter wanted to think about ways to shift from going from a binary to more of a continuous approach to assess social risk. 42% wanted to start measuring well-being and resilience more, and not just the absence of resources. A third wanted to measure and track social determinants of health at an institutional or community level, and not just at the individual level. And then we'll try to follow up with the 2% of you who responded about other as well. But with that, let's shift back to the presentation. And Brita and Karis, and for everybody on the line right as well, we wanted to just reflect back on some of the things that we're seeing in this moment. And this conversation today really reminds us that there are many things that prevent us from kind of sharing that common language and sharing this approach. And already we're starting to expand our understanding, expand the dimensions of our understanding of ways we can measure success when it comes to moving upstream. One of the things that we're seeing, especially relevant right now, perhaps for many of you who are joining in today, is that one of the problems with one of the Tower of Babel kind of phenomena that we're seeing right now is that even the term social determinants of health is meaning different things to the folks who are using it. There are those who are right now talking about social determinants of health, but what they really mean is a social determinant of health care. So for example, transportation. Many in healthcare, especially hospitals and doctors' offices, et cetera, who are talking about social determinants, look at an issue like transportation and say, well, we're really interested in transportation because we know that's an important social determinant of getting access to a doctor, getting a ride to the hospital. And so that's a very social determinant of healthcare focus. It's a healthcare reference point. That's distinct from others who may have a social determinants of health kind of framework, how we're defining it here, which is going back to the example of transportation, a situation in which the institution may be interested not only in transportation to the doctor or to the hospital, but also whether that individual has access to transportation to childcare, a job, a park, etc. So that's a social determinants of health reference point. It's more of a community reference point. And then there's others who are using social determinants of health to be able to bring more attention to the questions of health equity. And so, for example, going back to transportation, the question from these stakeholders is not about whether or not there's transportation necessarily to a doctor or to a park or to a job or childcare, but a more fundamental question about why there's no transportation available in one community. Why are there no bus lines, for example, in one neighborhood compared to others, et cetera? So it's questioning the allocation of resources. And so this is, from our perspective, a really important first set of questions to start answering as we start to define measures of success. And as we go back to these questions of dimensions and think about our objectives, we're also seeing that there are a variety of different objectives that that different stakeholders who are coming together in this movement upstream are interested in. There are some who want to use data on social needs to inform clinical decision making and care. So this is an example of where a clinician may use the data they collect on a health-related social need in their system, in their clinic, to be able to adjust the treatment plans they make for an individual patient. For example, a person with diabetes who experiences food insecurity may need a slightly different care plan so that the clinician can make sure that they're not inappropriately taking blood sugar lowering medications on a day when they're skipping meals. There's also interest and objectives to use data to connect individuals to non-health services, and I think we've heard a lot today about exactly that. I think there's a lot of interest primarily in this at this point, especially from healthcare systems and health plans, to be able to make sure that individuals who have these health-related social needs are getting connected to the services, the social services that can address those social determinants. There's also interest in informing continuous quality improvement, both within institutions, within, for example, healthcare institutions, as well as non-healthcare institutions, right? How can this data be used to be able to track continuous quality improvement, and not only within institutions, but also with partners as these emerge, as more and more clinical and community partnerships emerge. From a policy perspective and from a population health perspective, there's also an interest in looking at data to identify hotspots in certain communities. There's also this notion that has been recently kind of discussed in some of the academic literature about identifying cold spots, areas where there's a relative lack of resources and where there may soon be a hotspot because of impending crises that are going to come about because of the starvation of resources in that community. So rather than looking at high utilizers in the hotspots, how can you look at cold spots in terms of the absence of resources that may lead to high utilizers downstream? There's also interest to use data to inform policy as well, and I think we've heard a little bit about that discussion too. So these are important considerations, and as Brita and Karis, you were thinking about this, and you're thinking about some of the emerging kind of attempts to try to create a common language, including the National Center for Vital Health Statistics framework, which is a really robust framework to help think about how we can systematically think and talk and act with respect to health data. I'm wondering what you think about this notion about how to create a common language. Are we doing okay in terms of using the common language these days? And Brita, especially given your experience knowing what the National Center for Vital Health Statistics is doing, is this a helpful framework? Are there others that are out there that can help provide us a common language? How do we take what you've presented, what Karis presented, what we've been talking about today, and create this common language? Brita, I'll turn it to you first, and then Karis will turn it to you and get opened up to questions.
Sure. I think this framework and language works well, but there are several others that are similar. I think the key is just making sure that we're always thinking about the individual in the context of their surroundings, their community, their neighborhoods, and the policies that are influencing their health and health behaviors. And the reason I think this framework and others like this are so important is really just in general, our society traditionally has been very focused on the individual. Even in medicine, there's a movement towards precision medicine and how do we make things exactly right based on the genetics for this single person. But every person is influenced by all these other layers on top. And so for that reason, I think whether it's this MCBHS framework, if this resonates with you, or similar kind of social ecological frameworks that embed the individual within the community are sufficient.
Thanks, Brita. And Karis, what are your thoughts? How are we doing in terms of a common language? And through today's conversation, especially, what do you think are kind of next steps for the work that you're doing in San Diego, the work that you think the risk rating scale can inform when it comes to developing that common language?
Yeah, no, I think we're in the right direction. I think we're starting to ask some of the right questions, but I definitely think we're in the very beginning and still learning a lot of things. I like what Britta said about, it's really this micro, meso, macro, kind of framework of being able to understand the bigger picture. And I think something you always talk about too is just like the equity elements of like where people are in the situation. And even on a risk rating scale, it doesn't account for a lot of the equity, like race and gender and some of those other really important in your neighborhood and your zip code and all these other elements that really like are almost multipliers of where those issues or the resources available in your community and all those kind of things are really constraints to being able to be successful and healthy. And so being able to really like take these type of tools that are really on the individual level and then start using it to help look at your community in a bigger picture and where do you invest resources and what are the challenges and how does it link to bigger health outcomes in specific neighborhoods and things like that. And so I think it's definitely these frameworks are really helpful, and I think they're evolving in time. We're learning as quickly as doing, where a lot of us are building the airplanes as they're flying, but it's exciting to see that there's consistency as more and more people are starting to look at it from different perspectives. Sounds like we're all kind of seeing some of the same things. It's just a matter of figuring out how to continue to move the needle forward.
Karis, thank you. And you mentioned that we're asking the right questions. Well, I think the best questions to ask are now the ones that have come in through online. So I'm going to turn the baton over to Sadhana here, who's going to group some of the questions that have been coming through for each of you here.
Thanks, Rishi, and thanks, Brita and Karis, for great presentations. We have so many questions, which is great. We're going to try to get through as many as possible, and I want to let the participants know they can continue to send in questions through that box. We will try to group as many as we can and also answer offline if we run out of time, so please keep your questions coming in. There were some clarifying questions on some materials that Rishi, you mentioned, and Karis, that you had mentioned. One was on the capabilities framework, and the other was the Lauren Taylor article. So if you both could just mention the title again, and we'll send out links to those after.
So the article I was referencing is called Capability as Clinical Success. It's an article I believe is in Annals of I believe it's the Annals of Family Medicine. I'll have to look it up and I'll work on that offline and send it out by group chat to everybody.
And then Karis, do you have the Lauren Taylor article by any chance?
I'm looking it up in my email as we speak, and I will find it and tell everyone in just 1 second.
Karis, it turns out, and a shout out to Marcus Heisler, who just forwarded the link to everybody in the group chat. So we'll copy that over and send it to everybody. So Marcus, thank you for finding that reference.
Thank you.
Thanks, Marcus. So that's really helpful. There were a group of questions regarding the risk rating scale, Karis, that I'd like to lump together for you. It's regarding how can people have access to the data? Are you accepting research partners? Are there any publications available about the work that you've done? So a number of questions along those lines. Can you speak to that?
Sure. Yeah. So, I think we have some resources, and we are starting to explore research opportunities currently. So on our website, if you go to ciesandiego.org, we actually just published a toolkit yesterday on what a CIE is, and some of the concepts of the shared language and the risk rating scale are in that tool. And then some of our recent publications are on that website. You'd be able to look and see that. And if for anyone that's interested in research, feel free to email me directly, and I'm happy to talk through, any research opportunities. I think we're kind of in the beginning stages of figuring out how to make this work and if this can work in other communities. So I think that's really our goal, as I mentioned. So we're open to that and hoping that other communities that are trying to do this work would adopt a similar framework.
Thank you. And so, Brita, I'll address the next question to you. And one of the questions was, what's been your experience with expert versus lay perceptions of rated well-being? So to what degree do the categories being used by service providers for assessing social determinants of health resonate with those who are being assessed? And what other facets are identified by those being served?
Sure, it's an outstanding question. There has been, I think, an increasing amount of work, especially from the field of psychology and positive psychology and well-being. And in general, there are two kind of camps as to how you measure well-being. One is kind of an overall and global sense of well-being. Another is domain specific. And within that, it can also be kind of the experience of positive or negative feeling. And so those groups have sort of been coming together in that many of the newer assessments of well-being include both of those as like a holistic picture of well-being. So that's kind of the expert opinion. But because that's the expert opinion, and when we have a lot of control over, especially an assessment in the scientific literature, those assessments can get quite long. So while they're very comprehensive, and I use them for my research work, those assessments are really not feasible for lay people to be able to administer. And so the lay perspective of health and well-being, I think it resonates well, or I should say aligns well with the expert opinion. Maybe people don't phrase it the same way, but there was actually a group out in the Seattle area that recently performed really just some focus groups of lay people to ask them, what they think well-being is, and what are the domains of well-being. And naturally, what came out were very similar domains, physical, mental, emotional, social, and a sense of meaning and purpose or spiritual well-being. So I think, when you just ask people, these are the things that matter to them. And I will say our experience in using the very brief assessment of well-being has been really positive. And actually, most people very much just appreciated that that they were being asked about parts of their lives that are very important to them that typically, especially in a medical environment, are not assessed. So I think the lay perspective of well-being really does align well with the expert perspective. People just use slightly different terminology and have different capabilities for measurement is all.
Thank you, Brita. That was great. I think we have time for one last question. And like I mentioned, we'll group these and answer them offline because there are way more than we can get to right now. So this question comes in from Ava Powell. What role do you see health plans playing in measuring social determinants of health? And so, Karis, I'll send it to you first, and then maybe Brita, you second.
I think great question. I think health plans, to Brita's point, I don't think everyone has the capability to do assessments. I think health plans and healthcare needs to invest more in community-based organizations who can help provide this work in the communities where people are living, working, playing. That really needs to be the concept of that. And so being able to invest in social service providers or nonprofits or CBOs that are providing the services that people are identifying as needs, like housing or food or whatever those social services are, and giving them tools like risk grading scale to be able to measure success in a powerful way so that you're able to continue to fund these organizations by meeting metrics that you need to meet on healthcare utilization or, well-being, all those kind of things. And so where we really see this being useful is being able to invest in these types of models so that social services who are trying to kind of do a lot of many different things have the right measurements and tools that really account for the ROI or the bigger, picture outcomes that healthcare is expecting. And so being able to really support organizations with tools like these so that you're seeing success and they're seeing success and measuring the right success measures. That's my opinion.
Great. And I can take a very quick second to respond and just say that, as long as information is not being used to change people's rate within for their health insurance, I think health plans really have a great opportunity and a lot of leverage in helping with measurement of social determinants at both the individual and community level, and can really have a great impact because they're getting all of the information about the healthcare utilization all of their participants are using over the course of the year. But in addition, they could link that with information about the local community and community organizations that can also help support the patient's health. So I think there's a great opportunity there.
Thank you, Brita. So we're past time, so I just want to say our next steps are to complete the follow-up survey. Please share your insights and ideas, and please stay engaged to learn how to continuously improve engagement of clinic leaders and staff. We'll be sending some follow-up materials, including links to the articles we mentioned, contact information for our speakers, and just wanted to thank you all for joining us, speakers and participants. Hope you have a great day.